Welcome everyone to today's Clinicians Roundtable. We have Renegade Research team over here, and the goal of the Remission Biome and Renegade Research Roundtable is to bring expert clinicians from around the world to share their expertise, best practices, so that the pool of clinicians treating infection-associated chronic conditions and all the comorbidities can be expanded. We have some upcoming roundtables as well, an AMA with Dr. Ruhoy and Dr. Kaufman on May 1st. Todd Davenport is coming on May 3rd, and Dr. John Houghton on May 17th. And then we have a 3-part series with Dr. Afrin coming up in June. So please subscribe so you can you can stay informed of all of the events that we have to offer. And today we have Amy with us, Amy Hyde-Smith. And Amy comes from the United States and has moved to Spain. And she is the director in charge of surgical cases at Dr. Gilete's office. Dr. Gilete has had an emergency surgery today and may not be able to join us at all or till the end. But Amy is expert, knowledgeable, and works very closely with Dr. Gilete in order to take care of the patients and support in a patient-centered care. So welcome, Amy. Please take it out.
Thank you so much, Isabel. We appreciate the opportunity, and I once again want to apologize on behalf of Dr. Gilete. We've had this on our calendar for at least a month or two, and he was hoping to be here with you guys today, and he might still be able to check in if he is able to get out of an emergency surgery. He had an emergency case present yesterday that couldn't wait until next week. So I do apologize. He is given me the go ahead and present a slide deck, kind of going over a little bit about diagnosing cranial cervical instability in patients with ME/CFS, long COVID, and hypermobile patients, as well as looking at tethered cord in that same population of patients. And so I'm going to present the information, and as we go along, if there are questions, I don't know, Isabel, would you prefer we leave questions to the end, or how do you like to do this?
Yeah, there's questions in the Q&A, and the team will route those questions, and we'll have some at the end as well.
Perfect. All right. So then we'll just move forward then. Just to explain a little bit about who we are. We are a specialist center located in Barcelona, Spain. Dr. Gilete has been practicing neurosurgery for over 25 years, but has become a specialist in the last about 8 to 10 years. And currently our clinic, about 45% of our patients have some kind of diagnosis of ME/CFS, long COVID. We even see in some Lyme patients, so post-infection patients, and then about 45% of our patients have some kind of connective tissue disorder, suspected connective tissue disorders, like Ehlers-Danlos syndrome, and then the rest of those 10% of patients are whiplash accidents, presenting with usually with CCI AAI. This is our bread and butter. We don't see hernias, we don't see brain tumors. This is what we do. We deal with this very small niche population of patients. We have a group of other doctors and medical professionals who work with us as we try to provide more of a multidisciplinary treatment to our patients, because they are so complex. They come to us with all the comorbidities you would expect. So we try and keep a really, really tight group of professionals who are very familiar with these comorbidities. And we'll talk about that a little later. We're lucky that we have some good relationships as well with clinics around the world. We've been really, really lucky to have a good relationship with the Bateman Horn Center in Salt Lake City, Utah, over the last couple of years, where we've done some cross training. They've taught us a lot about ME/CFS, and we've shared a lot of information about the spinal affectations in these type of patients. And then we work with a variety of other clinics throughout the world, just trying to share information and learning. And we're always looking for more opportunities for collaboration, because we feel like there are two ways to learn. One of them is, the first is most important, is listening to patients. They are the experts. When you have a chronic illness, you have a lot of free time, and they end up knowing more than we do. And so if we don't use that available resource, we're really missing out on a really great resource for information. A lot of times we find out about new studies from patients. And of course, they are the expert on their own condition. They are the expert on their own bodies. And then our colleagues are a great source of information, of collaboration. And so relationships are really important to us, both with patients as well as with other colleagues. So we're always looking for opportunities. We're excited to be here today and to collaborate with this training and Roundtable, and hope that it's mutually informative. I'm just going to go ahead and share my screen, and we'll get started with the presentation that we have. Dr. Gilete's prepared. What we're going to be testing today is just the biomechanical issues, specifically cranial cervical instability, Atlantoaxial instability, and tethered cord, as it relates to patients with ME, long COVID, and hypermobility syndrome. As I mentioned, that's basically our patient population. How patients get to us is 100% word of mouth. With the world that we live in today, a lot of that actually comes from social media. Patient groups, there's a lot of patient groups out there, and so we get a lot of referrals from other patients. Kindly allow me to introduce you to Dr. Gilete. He's not here, unfortunately. Dr. Gilete is a neurosurgeon working out of Tethered Medical Center in Barcelona. As I mentioned, he has a little less than 10 years working as a dedicated sole focus on these conditions in patients with connective tissue disorders and ME. We work with a specialized team of cardiologists and internal medicine specialists, endocrinologists, mental health specialists, and a lot of other specialists. Not included here is anesthesiologists, pain management specialists. So we really, really focus on the whole patient. We have a really specialized evaluation protocol that I'll introduce later. And we have a specialized ICU post-op protocol for patients with EDS and ME/CFS. Our nursing, a lot of this has changed since COVID because of the nursing shortage. But, every 6 months, we are sitting down with our nursing staff and doing trainings on MCAD, on POTS, ME/CFS, showing Jen Brea's films. And then we have our anesthesia protocol that we published 2 separate papers on. We use a opioid-free anesthesia approach, both for anesthesia and pain relief, just because of the negative effects that can come from using too many opioids in patients, especially with mast cell activation disorder, as they're histamine releasers. But where we have having really good results from using this opioid-free pain relief and anesthesia protocol. So the question is, why all of a sudden are ME/CFS patients presenting, and I need to mention post-COVID, patients presenting with CCI and or tethered cord? And you have some reasons here. We don't know. That's the answer. We don't know. We don't know if there's a genetic predisposition. We don't know if there's triggers with inflammation. We don't know, as I mentioned, so it could be a chicken or egg situation where perhaps it's a congenital issue, especially with tethered cord. So we're still learning, and hope that the positive side of COVID is there is a lot more investigation and study going into post-viral infection, post-viral cases and ME because of post-COVID. So hopefully we're going to get some more information in the upcoming years about where this is coming from, why our patients are presenting as if they have a connective tissue disorder. Oftentimes professionals ask us, so what's the difference in your treatment between ME/CFS patients and EDS patients or hypermobile patients or connective tissue patients? And honestly, we treat all of our patients as if they have a connective tissue disorder, because in the end, the comorbidities are the same. Oftentimes recovery is similar. I will tell you that ME/CFS patients often have a harder recovery than even patients with a genetic disorder like EDS, just because we're constantly fighting PEM, and because sometimes there might be an underlying inflammation or immune factor underneath that's preventing recovery. So ME/CFS patients are quite complex, but like I said, we basically treat all our patients as if they have a connective tissue disorder because they present very similarly. So we're going to move into diagnosis. I will remind I'm not a doctor. However, I do all of our patient screenings, and so I'm very familiar with the diagnostic process just by osmosis, just by the years and years I've been with Dr. Gilete. But I do want to make clear I do not diagnose, and I'm not a doctor. But I will go over our just the process of diagnosis that Dr. Gilete uses that I'm quite familiar with. So the challenges to diagnosis are, of course, the overlap in general with other comorbidities, dysautonomia, POTS, MCAD, small fiber neuralgia. All of these can appear, especially in patients with hypermobile syndrome and connective tissue disorders and ME/CSF. What are some of the challenges directly to diagnosis? Unfortunately, is professional ignorance. That doesn't sound very nice, but it's just, unfortunately, it's just the way it is. These things are not necessarily taught in medical school. They're not taught even, in specialty courses. So a lot of times, what we encounter, actually we don't encounter, patients encounter it, is this idea that CCI AAI only appear in patients with RA or with Down syndrome. That's what they studied. That's what they think. And so when a young female patient appears, and I'm sorry. So when a young female patient presents and says, I suspect CCI AAI, and all they have ever been taught is that it only appears in rheumatoid arthritis or Down syndrome, they're going to dismiss because they don't have the information available. Tethered cord, most neurosurgeons even are taught how to diagnose tethered cord in infants. And so they're looking for conus descent. That's all that they've ever been taught to diagnose tethered cord, is they only have one diagnostic criteria, and that's conus descent. And that doesn't always apply in adults, and especially doesn't always apply in patients with connective tissue disorders. Lack of appropriate imaging. We'll talk about this a little bit more further down, but for CCI and AAI, we need dynamic weight-bearing imaging, and you can't find that everywhere. In the United States, I believe I can't remember, it's 13 or 16 clinics with upright scans. Here in Europe, we've only got a handful as well. And then imaging alone does not mean anything. Dr. Gilete has this highlighted. Clinical radiological congruence is essential. So I will tell you, Dr. Gilete uses angles and measurements only to diagnose, not to determine the progression and the need for surgery. That 100% comes down to the clinical congruence with the neuroradiological presentation and measurements. So symptoms are really important, and they should line up with the diagnosis. The other challenge to diagnosis, of course, is there are very few specialists. I could be mistaken, but as far as we're aware, there's only 3 dedicated neurosurgical specialists in this area, and it's Dr. Bolognese, Dr. Henderson, Dr. Gilete. There are other neurosurgeons who do dedicate some of their practice to this group of patients, but not the full focus of their patients. So we're talking about just a really small group of specialists here. So this is kind of hard to see. I'm just going to tell you what it says. This is the MA diagnostic criteria: fatigue. You guys are all familiar with PEM, the sleep dysfunction, pain, neurologic cognitive manifestations, and then this whole long list of other issues. And then the chronic factor and ME. So what we're kind of talking about here is how there's crossover between CCI symptoms and ME/CFS. So it's hard to know, is this patient just presenting with your standard ME/CFS, or do we really need to dig deeper here? And is there some kind of mechanical issue going on? Here again is some additional symptoms involved with specifically CCI. And then once again, we're looking at MCAD. So once again, we're looking at a lot of the same issues: headaches, migraines, brain fog, fatigue. We're looking at POTS. So there's just a lot of myalgia. I mean, there's a lot of overlap in some of these things, and so it's really important that we're treating what we can before we get to the really complex things, before we jump to the assumption that this patient's presenting with instability or tethered cord. We need to make sure that these other things that are more easily treated, I put in finger commas and finger quotes, but that can be treated with other ways, medication, with professionals, before we start jumping to a suspicion of some kind of mechanical diagnosis. So here's some practical tips as clinicians, what to look for in a patient who may be presenting with CCI, with AAI, with tethered cord. So we've split this up into online and face-to-face because this is how we personally work. I don't know the rest of you if you're seeing patients both in person as well as telemedicine, but this is what we look for. So when we're looking at online, of course, we're limited in what we're able to look for, but we're going to go through some screening questions and we're going to kind of evaluate the patient. Are they hypermobile? Are they hypermobile? Do they have a diagnosis of ME/CFS? Let's talk about some PEM. Do they feel worse when they're upright? Do they feel better laying down? But remember, that could be POTS as well. Do they have POTS? So if a lot of times these things present together. So do they have POTS? Do they have mast cell? Has there been some kind of accident trigger? Even patients with EDS, hypermobility, ME/CFS, oftentimes are managing their symptoms and then they have an accident and everything falls apart because the tissues and ligaments were weak. Do they improve with a cervical collar? Have they, I don't want to get into cervical traction here. Our personal opinion, cervical traction should, manual traction specifically, should only happen in the hands of a specialist. And as we just mentioned, there are only a small population of specialists. So be very, very careful with manual traction, especially in the hands of a physical therapist or a chiropractor who is not familiar with connective tissue disorders. So, but once again, going back to this question, does the patient improve with cervical traction, making sure it's done in a safe way? Relationship to head movement, meaning do their symptoms get worse in flexion, extension, rotation? Bobblehead. I sometimes in patient screenings, I'm going to say a word, and I say bobblehead. Does that resonate? And so this idea that your head's just too heavy for your neck. Then we're going to ask about urinary issues, specifically retention, incontinence, frequent UTIs, and frequency. Those are the things we're looking at. And we're going to look for GI issues. And the thing that didn't make it onto this list is, I think is on the later list, but then we ask also about sexual dysfunction. If they're bedbound and have light and sound sensitivity, difficulty without additional testing. So what this is about, so patients who are said bedbound or have extreme sensitivities, not just to light and sound, but sometimes even to chemicals where they can't even bear leaving their homes. The difficulty that those patients present with is they actually can't leave their house, or they can't come to a diagnostic center to do scans. And so they need additional testing. The first thing that we use in that population of patients is a cervical collar with some mild traction with like an Aspen Vista, where the Aspen Vista, if you're not familiar with it, You guys can't see me, but it has a little dial in the front where you can adjust for mild traction. We've never seen a patient with traction trauma from a neck collar. So it's something we feel safe, but we always allow the patient to try to adjust the traction themselves. So for this population of patients who are bed bound and can't easily come to a diagnostic center, the first thing we'd ask is for them to try a cervical collar with light traction to see if they improve. And then for patients also who are bed bound, sometimes they require direct admission for additional testing because they're not able to do it outpatient. That when we're dealing with a face-to-face patient, we're looking at all those things that we just mentioned, all those criteria, all those hints that we looked at, plus a clinical examinations or a neurological examination. So we're looking for paresis, hyperreflexia. We're looking for oculomotor reactions. We're looking for Hoffman. That's the finger reflex, the popping your fingers to see the reflex there. We're looking for clonus, tremors, and involuntary movements in general. Romberg, so those are all within a neurological examination. And then we're asking them to walk, and we're evaluating their gait, especially toes and heels, to see if their legs just kind of falter, see if there's weakness in the legs. Then we're checking out their breathing and asking questions about breathing, if they have to remind themselves to breathe. Patients who have breathing issues oftentimes have something called superior odontoid migration or cranial settling, which is, we're talking about actual vertical instability, where the odontoid could actually be entering the brain space. And then, of course, extreme fatigue. So those are some of the things we're looking for clinically in a patient, symptoms that we can be looking for either online or face-to-face, so to give us some clues as to whether or not it's worthwhile to pursue an additional testing and diagnosis. So moving specifically now into tethered cord, we're looking for urinary issues. That's always the big one. That's red flag. As we discussed, urgency, frequent urination, sensation the bladder doesn't empty completely, trouble with beginning the stream, frequent UTIs, incontinence, gastrointestinal issues, gait problems, weakness in the legs, low back pain, inability to lay down without bending the knees. That's a big one. Or you'll see a patient, sometimes when I'm doing screening, I see a patient and we're connecting by Zoom and they have their knees tucked into the chair, and I'm just like, red flag. So the sensation that they feel better when they're in the fetal position or tucked in. And sexual dysfunction, mostly for men, especially erectile dysfunction. So if you're looking at this list, you're going, but Amy, these issues that present patients with EDS, for example, have stretchy bladders. So of course, they're going to have urinary issues. Patients with MCD have really awful gastrointestinal problems. So we kind of really have to put all this info together, rule out what we can, and then try and what's left over, try and kind of put some puzzles together and trying to figure out where everything's coming from. And that's when we'll move into later diagnostic criteria. But these are the first things we're looking for is symptoms, so that we know it's worthwhile to move forward with the diagnostic tools. So some other issues we wanted to take into consideration with patients in this population is internal jugular vein compression and Eagle syndrome. Oops, sorry about that. I was just trying to move my screen because I couldn't see if there's something below there, because I've got my little Zoom panel here. Chiari, oh, there we go, Chiari. So these are some other issues that we need to look for. I will just make a quick mention about Chiari. The Chiari diagnosis has changed dramatically in the last, say, about 3-4 years. I will admit that 5, 6, 7 years ago, we were doing a lot of decompressions, and we rarely do them anymore because we've learned that what we were taught and the diagnostic criteria from 5 years ago was only based on sorry, I can only think of the word in amygdalas, tonsil descent. There we go. We're only looking at measuring tonsil descent. And since then, that's been thrown completely out of the window, and measurement is not, you can have a patient with really descended tonsils, but as long as it's not blocking the CSF fluid, and as long as they're not presenting with symptoms of Chiari, then we're not going to treat it. We're not going to open up their brain, open up their skull, and decompress. So I just want to mention that Chiari diagnosis has a diagnostic criteria has changed drastically and for the better for patients, because there are a lot of unnecessary decompressions happening several years back, especially in connective tissue patients, because they just have stretchy tonsils. But as long as, and shape, we're looking at the shape of tonsils as well. And then the other thing on the bottom of that list is IIH, so intracranial hypertension, which oftentimes is related to internal jugular vein compression as well. So those are the other things that we need to be looking at, because they can present as well with these patients. There could be other neurosurgical issues that we need to look at and rule out. Okay, so now we've looked at those. We suspect CCI or tethered cord based on those symptoms. Now, what do we do? So the best thing, the easiest thing to do is also, especially as a clinician who may not have all these tools at your disposal, may not have an upright clinic close to you, or maybe don't have a knowledgeable neurosurgeon close by to you, then what is your next step? And your next step the easiest thing to do, as mentioned, is trying a collar. We really like the Aspen Vista or the Miami J because they're adjustable and can apply a gentle traction. Now, just a reminder, we're applying traction, not extension. So make sure that the neck is not lifted up, because actually can provoke worsening of symptoms in some patients. So make sure that it's fit well, and that may require a trip to the orthopedic center. Or to a knowledgeable neurosurgeon. But that is something a patient could try in an office, in a clinical setting, or if in a desperate situation, they can even just try at home. I will tell you that a lot of patients just order them off of Amazon. It's not ideal. But once again, it's relatively a safe way. We've never seen in our patient population, we've never seen a patient who's had a traction injury from a collar, but there could be one out there that I'm not familiar with. So just keep that in mind. Traction is dangerous if it's not done carefully, but a collar is generally a safe place to start and can give you some really good clinical information. So it is the cervical collar can be a diagnostic tool for three factors. One is the stabilization already. Just not moving the neck is going to give them better an improvement to their symptoms, and then the mild traction as well might give them some improvement. So based on that, if those results are positive, meaning that we're getting some clinical information from that, we're getting some improvement. And so I'm going to start with improvement right now, improvement to their symptoms. Then what do? Then we move on with the diagnostic tools. So we're going to send them for an upright MRI, flexion, extension, and rotation. In Europe, they do flexion, extension, rotation all at the upright MRI clinic. Flexion extension, really important to have sagittal imaging. Rotation, really important to have axial imaging. However, in the US, they do not do rotational scans in the upright MRI center. So you have to order, to rule out Atlantoaxial instability, you have to order a rotational CT scan. So as far as imaging goes, is much better because we're looking at bone instead of soft tissue. However, it's just an extensive amount of radiation. So you need to advise your patient of that and keep that in mind. One thing you can do to reduce radiation exposure in these three scans, so neutral, left, and right rotation, is minimize the field, because we really only need to see like C0 to C3. We don't need a full cervical CT in left, right, and neutral rotation. The other thing you might want to order is an MRV. Here in Barcelona, we have a really great resource with the diagnostic center that we use, that we're able to do vascular studies, both arterial and venous scans, without using contrast. With a 3 Tesla machine, we're using time of flight. That is preferable. Just because a lot of patients with mast cell activation disorder may react to contrast. So that's a really big issue to keep in mind, is trying to avoid contrast in these patients initially, especially if they've never had contrast before, because they can react. And if you're sending them to a center that's not prepared for that, that can be really, really scary. I would like to introduce to you our tool here in Barcelona for upright imaging, which is called the upright CBCT machine. A CBCT machine is a cone beam CT scanner. It uses 1/60 amount of radiation as a conventional CT scan. And so we're able to do flexion, extension, rotation left, rotation right, and neutral. And we do actually neutral in supine and in either standing or sitting. So it's 6. So basically 6 scans for the price of 1. So 6 scans with basically the same radiation as a conventional CT scan. And the CBCT scanner is also definitely preferred over an upright MRI because of the quality of imaging. An upright MRI machine, the phonar machine, which is the best upright, and the only one we actually prefer, the only upright MRI machine that we prefer is the phonar machine. It is 0.6 Teslas. Your standard MRI machine is 1.5 Teslas. Your good MRI machine is 3 Teslas. And so we're dealing with really, really poor quality imaging with an upright MRI. Other downside to the upright MRI is those patients who are already feeling pretty poorly. We're asking them to hold flexion, extension, and rotation for 15 to 20 minutes for each position. And that is a lot to ask of these patients. I've heard of patients going straight from the upright center to the ER. So the other benefit of the upright CBCT machine is that it, like a CT scanner, we're able to capture actual imaging in 20 seconds. Now, the patient is holding the positions a little longer. That is, we calibrate the machine, and as we do positioning, make sure that they're centered in the machine. But on average is about 3 to 4 minutes. But the actual imaging capture, where they're in the full flexion and full extension, full rotation, is 20 seconds. So it's much more comfortable for the patient. And I will throw out there too that a CBCT machine costs less than 1/10 of what an upright MRI machine costs. So cost to patient also is better. However, challenge is that we know of, we're the only ones using the CBCT technology. We're currently in the process of publishing a paper on our CBCT protocol, hoping that it expands the use of this technology, because it's really phenomenal, both cost, comfort of patient, and quality of imaging. The only downside of the CBCT, only downside versus an upright MRI, is that for a patient with Chiari, an upright MRI machine is better. But like I mentioned, once again, a supine MRI can show Chiari if we're looking for not just for tonsil descent, but looking for CSF flow. We're looking for symptoms. We're looking at the shape as well as the tonsils. Anyway, so that's the introduction to CBCT. We're really excited about it. It's something we've been working for years. We've been using it now for a little over 3 years. We love it. It's awesome, and we're excited to share it with everybody else. The one thing I haven't talked about then is this lovely little second point here on is lumbar prone MRI. So what could happen with patients with tethered cord is that when we're doing traction with the collar, they might actually start feeling some improvement, but some things may get worse. So patients who have tethered cord, oftentimes in traction, will have worsening symptoms down below, quote unquote. So they might be having more urinary frequency, they might be having more retention, they might be having really bad back pain, more problems walking, they might be having more involuntary movement. So that we consider also a positive clinical information, because then it tells us, hey, maybe we put CCI to the side for a moment, and we focus on really what seems to be affecting the patient's quality of life, and we start really digging into tethered cord. And our first diagnostic tool beyond symptoms for a patient presenting with possible tethered cord is a lumbar prone MRI. I'm going to show you later why, but this is also not common use in neurosurgery looking at tethered cord. But I'm going to show you later why we use that scan and some examples. So I hope I'm using my time wisely here. I'm a real talker, guys. I'm so sorry. Here we are. So we're into imaging. So why upright? So this specifically is looking at phone usage, but it's a good example of the importance of being upright. When you're laying down, there's no weight bearing. And so this is not the way we live. We don't live laying down. We're Homo erectus. We're upright creatures. And so patients' symptoms are presenting when they're upright. So we got to do upright imaging. That's why so many patients get disregarded or discarded by neurosurgeons or by neurologists, is because they're doing a supine MRI and it comes back normal. And that's because it's not weight bearing. And so the instability is not showing up because it's not in a normal, natural upright position where the weight is going to show that instability. So that's why it's really important to reflect the real physiological forces experienced by the patient. And that's why an upright scan is so important with right bearing positions, specifically in those dynamic positions that we discussed with flexion extension. Flexion extension is used to look at CCI, and then rotation. Rotation PS does not need to be upright because AAI is you're able to diagnose and to measure in a supine scan. So it does not need to be upright to look at AAI, but for CCI, absolutely. So we've already talked a little bit about this, the importance of upright imaging. So this photo we have here is actually the upright MRI in this patient's inflection. So you're saying, oh my gosh, my dentist has that, and you're probably your orthodontist or your maxillofacial specialist, and you are correct. It is the exact same machine. The visual field on this one's a little bigger so that we're getting as much of the cervical spine as we can. I don't have it in this presentation, but there are, and it is in our paper, there are some complications. There are some issues with the upright MRI machine, upright CBCT machine, excuse me. And one of them is the visual field in patients who are tall sometimes is not enough. But you can read that in our paper when we publish it. We've been working actually with the fabricante, with the manufacturer of some of the CBC machines to see if they can actually produce a machine that has a larger field. So once of all, we've already looked at that. So the downside of the upright MRI is the prolonged time in uncomfortable positions. MRI is primarily looks at soft tissue. It's not looking at bones. When we're looking at a MRI for bones, we're basically looking at the absence of water because MRIs look for water. Oops, sorry guys, I'm not really. A little whiplash there. Okay. CT, a normal CT, is okay for rotational scans like we talked about, but it is excessive radiation because there's 3 scans. So that's why we get really excited about the upright CBCT. I've already gone through all these issues. Here it says 1/5. It's 1/5 to 1/16 notes. I think what's published is 1/5. Oh, and then DMX. Let's talk really quickly about DMX. DMX is a great hint at the possibility of instability. Unfortunately, we're not able to make good measurements because it's only a 2D scan. So they're not produced in DICOM. And so DMX, especially with a neurosurgeon with a really good eye, can pick up instability, but it's not enough to do measurements. And the international criteria for diagnosing CCI and AI requires measurements. So a DMX for us is not enough for a diagnosis because we need measurements. However, we do like something similar to a DMX for looking at subaxial instability, which we're not going to talk about a ton here. But do be aware that a DMX is excessive amounts of radiation. Excessive. So much that I've been told recently that it's been outlawed in some countries because of the excessive amount of radiations. We use here in Barcelona to look for subaxial instability. We use a fluoroscopy machine without contrast, of course, and we do the scan in 15 seconds, whereas a DMX is literally, we're talking about minutes of imaging capture. Keep in mind, DMX is a great tool to show suspected instability, but in order to follow the criteria established by an international committee several years back, you have to have measurements, and you can't do that in DMX, and lots of radiation. Okay, let's keep moving on. We talked a little about the prone and supine lumbar MRI for tethered cord. So this is a picture actually of our prone MRI. So we have here, it's similar to your protocol when you're doing a breast MRI. So you have a head support that you can't see super well there, but the patient needs to, super important that head needs to be in a neutral position. So this patient will notice that there's We're publishing a paper on this too, P.S. The patient's chest has been lifted, and the head is in a neutral position, and we're using here a 3T machine. A lot of 3T machines these days have some special software that allows you to reduce respiratory artifact. What is it? Respiratory artifact? It's a fancy word for breathing. It doesn't stop you from breathing. It reduces the effect of breathing on the scan, especially with women, because we have breasts and we have fat. When we breathe in the prone position, we move. And so technology is catching up and improving the prone position scans. We'll tell you the majority of prone scans that we get from other clinics, besides our own, which makes me sound really snobby, are not enough or too blurry to diagnose, because I'll show you in a second why. We're looking at phylum. We're looking at hairs, basically. And so if there's movement, it's really hard to see. And so here we have the magic word of the day, AI. So the machine we use here in Barcelona uses AI to reduce respiratory artifact. It looks at the patient's breathing pattern and captures imaging when they're not breathing. So the challenges to prone position, we talked about it. Neck has to be in a neutral position. Respiratory artifact, some of that can be helped with technology and AI. And really important is a willing technician. Sometimes, even with all these fancy schmancy technology solutions that we have, patients, sometimes because they have superior odontoid migration, they have weird breathing patterns. And so we actually may have to go through and actually have a technician or tell the patient to do some breath holding while we're collecting some of these, some of the imaging capture. So that's some important imaging for tethered cord. And I'll show you later why. I'm going to show you some examples of these scans. I will let you know that this is my weak side because I've never been a radiologist and I'm not a neurosurgeon. But here, Dr. Gilete has provided us with some examples of imaging. So to our left is, hold on, let's cut it off here. I don't want to say this wrong. Hold on, just give me 5 seconds.
While you're doing that, Amy, I'm just going to mention that if you do have questions, if you can please put them in the Q&A, and then when Amy is done with her presentation, we will bring you on to answer the question. Or if you want to, we can also have the panelists ask the question for you. Thank you.
Okay, there we go. So so to our left, it got cut off, so I'm just double checking. To our left is a patient upright. And to our left on the screen, to our right on the screen is a patient laying down. This is the exact same patient. So do you see here the odontoid peg, how the position is different? So sorry guys, I'm just so used to not tapping here. So showing the importance of upright imaging. Now this on the bottom, these bottom two images are the exact same patients. Left is an upright MRI, and the right is a CBCT. And if you see on the left, the quality is really bad. Quality is really bad. And in order to do the measurements that Dr. Gilete and anyone following the criteria for measuring CCI needs, there are reference points. The palate is one of the reference points. The back of the skull is another reference point to measure Chamberlain line. Those sometimes are not clear in an upright MRI. And if you can see this patient on the left, exact same patient on the right, I can't even see the odontoid. I can't even see it. I can guess, maybe, I don't know if you guys can see my cursor. I can guess more or less where it is, around here somewhere. But this is not a good enough quality image to do a diagnosis, because I can't even really see where the odontoid is. So that gives you a little idea about the importance of upright imaging, and really when we're looking at a scan made for bones, such as a CT, or in this case a CBCT, how it is definitely preferable over an upright MRI. This here we're looking at AAI. So what we're looking at here is for overlap. And you can see that's so clear between the C1 and C2 here. I mean, it's almost completely dislocated. It's almost completely off of C2. So that's really apparent, especially in this 3D restructuring. The 3D image here, you can really see the overhang and rotation. This is an axial cut here, where because I am not a neurosurgeon, I couldn't really. Dr. Gilete shows me these images all the time. He's like, "Do you see that? Look how clear it is." And I'm like, yeah, sure, I see it. I'm not a neurosurgeon, but it's there. I can see it in 3D. And this is the same patient. So we know it's there. I couldn't tell you. I wish Dr. Gilete was here. And so I was just been checking my phone because he lets me know when surgeries end so I can alert families, and I have not gotten a message from him still. I'm just waiting for him to save me here. But hopefully you guys are following along still here and wondering why a non-doctor is explaining these things to you. So here's an example then of the measurements that we would use for diagnosing CCI. Here a patient's inflection, and you can see the importance of a clear image. This is of course is an upright MRI where the odontoid is nice and clear. He's measuring from the bottom of the odontoid there, and then looking for the distance and looking for a retroflex odontoid. And in this case, the patient, if my guess, he wouldn't have showed it to us unless it met the criteria for CCI. So this gives you just an idea of why it's important to have clear imaging and what some of these angles and measurements look like. They're very precise, and so we really need those reference points. Again, I apologize that I'm not a neurosurgeon. You don't want me diagnosing your patients. I can screen them, but I do not diagnose them. All right, here we have an example of our TOF 3D, time of flight, 3 Tesla 3D reconstruction of a vascular scan. And this patient here has internal jugular vein compression. This often it presents especially with patients with AAI. So what happens is, as we saw in that previous image, the jutting out can cut off this FC1 can cut off the flow of the internal jugular vein. And that can cause all sorts of symptoms, intracranial hypertension being one, but causing a lot of symptoms especially. And so that's why we didn't mention it earlier, but one of the first things I ask for patients, like, do you have tinnitus? And another tool we use is an ophthalmologist exam, so especially before surgery. So we have patients see an ophthalmologist, and we rule out papilledema just to double check that we're not dealing with some serious optic nerve damage from IAH. But a simple ophthalmological exam, looking at an eye fundus exam or campimetry exam, can look for signs of damage to the optical nerve or swelling around the optic nerve, which could be a sign of IAH and could be related to internal jugular vein compression. So all these things can present. One thing leads to another. That C1 jetting out can compress the jugular vein. The compressed jugular vein can then cause intracranial hypertension, which can then in turn cause papilledema, which can then actually cause blindness. So things we need to keep an eye out for as clinicians, you guys. All right. The other thing, of course, to look out for with internal jugular vein compression is Eagle syndrome, which is quite rare, but it's something also the CBCT is really good at looking at versus an upright MRI, is measuring the styloids. Okay, so here we are, and I'm so sorry. This screenshot, the quality is not great on the right hand side on the axial cut. But on the sagittal cut, this is a prone lumbar MRI. To your left, anterior, to your right, posterior. Okay, on the lumbar sagittal scan. So this patient, let's look at it in our head. This patient is on their stomach. And what should we expect to see in a patient in the prone position? is everything here should fall anteriorly, right? But what do we have here? This little fella right down here is just not doing what he's supposed to do because he's stuck, because this patient has tethered cord. What's the difference between occult tethered cord and tethered cord? As you notice here, it says occult tethered cord. Why can't we call it tethered cord when we clearly can see it on a scan? Because the diagnostic criteria for tethered cord still only depends on conus descent. So if a patient does not have conus descent, we cannot, quote unquote, legally call it tethered cord. And so the injustice is that we have a patient with clinical presentation of tethered cord symptoms. We have the clear imaging of tethered cord, and we still can't call it tethered cord. We have to call it occult tethered cord, which has the same diagnostic criteria as if we can't see it in imaging. It only presents in symptoms. And so that's something we're also fighting for, is that diagnostic criteria changes. Because it's a disservice to patients having to carry around a diagnosis. Occult as in if this can't be seen, but it can be seen. So here we clearly see the importance of a prone lumbar MRI, no conus descent in this case, but clearly we have the phylum attached here posteriorly and the patient presenting with symptoms. The axial side, we can't see really well just because the quality is screenshot. If you can see it, there's a bunch of little dots up at the top and one dot down below. And so this is another thing we would look at. We'd look at the clumping anteriorly of as the patient's in the prone position of the phylum, and then looking down below for any lone stragglers attached there to the arachnoid. Okay, so that's tethered cord and why it's important to have those really awesome tools of the prone MRI, which can be challenging because of respiratory artifacts. So we're neurosurgeons. We do surgery. I will tell you, of all the patients that contact us, only about 5% of those are surgical candidates. And not all of those end up having surgery. But surgery is something that may be need to considered for patients in advanced stages of progression symptoms. So here we just have a picture of some of our team, what our OR looks like, who's in there with us. We've got Dr. Judd, neurosurgeon. He usually has one or two assistant neurosurgeons who are not juniors or residents. They're full-fledged neurosurgeons. We have anesthesiologists. We have the neurophysiologists. We do continuous neurophysiological monitoring on site, one person, one surgery in the OR. And then we have usually a scrub nurse. Dr. Gilete does everything from shaving to stitches. And so we work a little differently. I'm an American, so I'm used to the way Americans do things, which is not the way we do things. And I don't know I don't know a lot of other surgeons, but here surgeons do a lot more what a lot of other surgeons might not do, but he does it all. We have a much smaller group in the OR because of that. Anyway, so this is what you see here, a lot of padding because these patients, so this patient here on the left, she's kind of famous in the EDS world. She is just casebook EDS patient. She had to wear braces into the OR because her knee subluxed, her ankle subluxed. So just in the prone is a really dangerous position for me, and I don't have a connective tissue disorder. So we just got to pad the heck out of these patients. We have a special table. I mean, this is why you need a specialist for these kind of surgeries, because there's so many things to take into consideration, or you're going to get some nerve damage. You're going to have some serious complications and risks with these very complex patients if you don't know what you're getting into. So you'll notice we have a really specialist team, and we have specialist equipment, and we've learned as we go what we need to do to keep patients safe. So some of those things to keep patients safe is our somatosensory evoked potentials, our motor evoked potentials, continuous throughout surgery. Like, so you see here in the picture here, on site, one patient, one surgery, one neurophysiologist in the OR. We have an intraop CT scan. We have an O-arm scan in the OR with us. And so we also do, the word just escaped me. We do preoperative planning using a CT scan. And the name of the word just popped right out of my brain. I'll think of it in just a second. Surgery is always the last option, exhausting all other options. And then even in the case of a patient who presents with the perfect diagnosis, the perfect measurements, what we're really looking at is quality of life issues. So do the potential benefits outweigh the risks and the cost? Surgery is always last option. Okay. And we don't work with cures here. Let's just be honest. Anyone coming to us for a cure of ME/CFS or to cure their EDS or to go back to quote unquote normal, we will not accept as a surgical patient. We work in quality of life, and we work in breaking the progression of symptoms. That's what we work in here. That's what we're working towards, is an improvement in quality of life, not for cure, not to be 100% normal. We're dealing with chronic illness here and genetic disorders. I've already mentioned this multidisciplinary team. Our patients have to go through psychological, psychiatric evaluation before we consider them for surgery. Readiness for surgery is super important for us. This is part of our screening before I even send a patient a quote for surgery. Why? And this is triggering for some patients, so I'm always really careful to explain why, because so many of these patients have been diagnosed as psychosomatic. These patients, a lot of them have medical PTSD. A lot of them have a previous, I'm so sorry, I have to go on mute for 2 seconds because this is Dr. G.
As I was saying just a little bit ago, please make sure that you, if you can, to be putting your questions into the Q&A. We'll try to see how many Amy can answer when she's done with her presentation, and hopefully Dr. Gilete may be able to join us. I don't know, she'll let us know.
He just called me, tell me he's stitching up. So I don't know, because he has to stitch up, clean up, and get out of the OR, so I have no idea. Fingers crossed. I apologize. Going back to psychological evaluation, before we accept patients as surgical candidates, patients come to us with PTSD. A lot of them have medical gaslighting and carry a lot of trauma. And a lot of them have diagnoses that in a lot of cases is plain and simple not true. It's just they've been discarded as psychological or psychiatric cases because doctors don't have the tool to diagnose them. However, some patients actually do have psychological and psychiatric valid diagnoses. And a lot of times it's the chicken or egg kind of issue. A lot of patients have mental and emotional issues because of their chronic illness, because of their chronic pain, and because of being gaslit for so long. And because of this desperate search for a diagnosis and for someone to take them seriously. So what does that mean? Does it mean we don't take patients with PTSD? We don't take patients with mental and emotional trauma and mental and emotional problems and anxiety and depression? All of them have that. Not all of them, but most of them do. What we're looking for is whether or not they have the tools available and at their disposal, and not just available. I don't want them having their toolbox, on their hip with the latch closed. I want it open, and I want them pulling them out all the time so that when the going gets tough during surgery, especially in a foreign country, people, it's tough. Those tools are already so used that they come out with no problem, and they're readily available for patients. So that's what we're screening for. We're also, it sounds crazy, but we also actually do a quick interview with family if the family's coming to with the patient. Patients have to be accompanied. We require patients to be accompanied. And so I usually interview the family member to make sure that they support the patient's diagnosis, they support the patient's desire to have surgery, and the family member, traveling companion, and surgery companion is actually, not going to impede their recovery. So we're really looking at a lot of things here. And then multidisciplinary team before surgery, patients are evaluated, cardiologists, internal medicine specialists looking at their muscle activation disorder in their POTS. like I just mentioned with the psychiatrist, and they're also evaluated with our anesthesiological team, and we're putting all this together as we make a surgical plan. Case evaluation is complex. We got some crazy stuff that comes up with these patients. I mean, just really crazy and bizarre stuff. So we need to know these patients in and inside and out. That's difficult for us because a lot of times we're in Barcelona and they're in Canada, or they're in Germany, or they're in Australia, and we don't get a lot of in-office visits. So we use a lot of questionnaires, a lot of Zoom visits to try and get to know these patients really, really well. Tethered cord can present oftentimes with CCA and AAI, so we really need to do as much information as we can to decide where we start, which is why traction is so important. We haven't really talked about the importance of traction testing. We rarely do halos. We rarely do an invasive traction. We use a device, an external device that doesn't use screws to do traction, and get really good results from that. It's an orthopedic device, and so we're able to do it without taking someone to the OR to put screws in their head to do traction. And so that gives us really great diagnostic information, so we can decide if a patient does have tethered cord and CCI, where do we start? So then we have, of course, the treatment and comorbidities. Those need to be under control. Those need to be under control before we have surgery, we consider surgery. And then, of course, we need to have preoperative care in order, which is very challenging for patients leaving Barcelona and going home where they don't have specialists, where they might not have a lot of support from the local team. So that is a huge challenge, is postoperative care. When patients come to us for surgery who don't live locally, which is 90% of our patients are out from outside of Spain. Surgery is the last option. Big one. Where are we on time? Shall I go into this case study? Isabel, would you like me to go into the case study?
Yes, we're good. You can go as long as you need to.
Okay. Okay. I hope everybody's still here with us, and got a quick case study. 95-year-old female from the UK, childhood onset of severe anxiety disorder with active depression, viral onset of ME at age 14 in 2011, diagnosed in 2014. After successful psychiatric treatment, ruled out anxiety disorders as the cause of symptoms. On onset, her symptoms were mild, but over the years that progressed pretty extensively, and by 2021, the patient was very severe, completely bedbound. Testing for CCI began in 2019 with an upright MRI done in the UK. She did a center radiology with us, and then to obtain clear imaging, she did an upright CBCT. We collected her patient history, symptoms, clinical exam, traction tile, all confirmed diagnosis. Pern and supine lumbar MRI, urodynamics. At that time, we're still doing a urodynamics. In 2021, we now no longer do urodynamics. We do evoked potentials, and they are awesome. And I didn't have a chance to talk about those. So all of that also confirmed occult tethered cord. So patient presenting with CCI AAI and occult tethered cord. So not fun. This is a patient, you see her, she's like gripping that wall because she can't stand. She's in a wheelchair. This is her imaging. We can see here see the tremors. Very unstable walking, tremors. So that's what she looked like before surgery. Waiting for this video to start. I think this is the video, or is there another? Oh, there she goes. Oh, I had to hit it. There we go. This is her 5 days after tethered cord release. 5, 6, 7 days after tethered cord release. So no more tremors, walking securely, comfortably, carrying her own IV bag. So pretty spectacular. We see some really amazing cases of patients who are paralyzed who haven't walked for years, and with a simple tethered cord release, they're able to walk again. And then, of course, we see patients on the other end as well who have a tethered cord release, and the only symptoms that improve are urinary symptoms. So not every patient looks as amazing as this one and responds as quickly. But, you know, these are These are all the ones that we show. We always show the exciting ones. But there are, of course, patients as well who only see mild improvement. So, ME patient, here is her upright scans. Here are this is the neuronavigation. That's what it's called. Neuronavigation planning Dr. G does. This is a Bendini. It's a really cool bit of technology that comes along with the machine that actually, it's kind of like GPS for your vertebra. It maps out where your vertebra are. So as they're applying the rods to fixate the spine, then they're bent actually exactly to your anatomical curve. So Bendini machine is pretty cool. 2 surgeries undertaken separately. Some surgeons will do this together. We hate doing them together. Not to say that we haven't done them together. Just patients, in my opinion, do not recover the same when they're done together. They're brutal surgeries, and done together, patients just do not recover as well as they would if they did them separately. So she had a section filum terminale with helimanectomy. I'm not even going to say that word. At L1, L2, L3 to access to open the dura and to section the filum. And Dr. Gilete's technique is very similar to Dr. Klinga's. He cuts sections and removes the filum. And then cranial cervical thoracic fusion from skull to T2. These are some serious surgeries, people, with interrupter traction and bone graft performed. We use donor bone. Years and years and years ago, we were harvesting ribs in EDS patients because the information we had at the time told us that EDS patients had a much higher risk of rejecting cadaver bone. But the intercostal pain, the CRPS, the issues with harvesting a rib from an EDS patient was just awful. So we gave that up a long, long time ago. That was back in the Stone Ages. And now we only use donor bone. We use the best of the best, gold standard bone material. And we don't really get many rejections, but we occasionally get some absorptions, like patients will just eat up the bone graft. But bone graft is really important to stabilize these really, really unstable vertebrae. Both surgeries were successful with no complications. 6 months post CT scan showed excellent bone growth and good placement of screws and hardware. And as of yet, no retether. Why do we say as of yet? Patients with EDS and especially ME/CFS have a really high rate of retethering. This is not a complication. It's because they have sticky tissue and they just tend to retether, especially to that scar tissue from the previous tether cord release. And so this is something we have to keep our eyes out for. What's the rate of retethering? According to the literature, there is no literature on ME/CFS and EDS patients, but on patients with equal complexities, it's about 15%. In our experience, it's higher, maybe more like 20 or 25. I'd be interested in gathering some information on that. So do be aware, retethering is very common in these patients and can happen sometimes more than once. So functionality and quality of life in this case study is preoperatively in 1 year, she had read only 6 books just because of cognitive issues and her eyes not being able to focus and like nervous system overload. Average daily step count was 200-500 steps. She had fancy Fitbit. Average heart rate for resting, standing, walking. You can see here, patient unable to dress themselves, completely dependent on others, bedbound, no social life, bedbound, housebound, no access to family and friends. The Bell scored 20. So 1 year post-op, 140 books read plus. Average daily step count, 3,000 to 4,000 with peaks of 6,000. Normal kind of step count. Resting heart rate, much, much better. Patient had a lot more autonomy, improved social life, and then able to leave the house with keeping a wheelchair close by in case she needs to sit down, mostly because of POTS, or occasionally walking with a cane, just as she works, especially as she works up her strength. Patient able to have a life, and then that Bell score improves. So this is only 1 year post-op. Patient is currently 2 years post-op, and I follow her on social media, and she's doing great. Patient previous to surgery, completed extensive investigative, logistical, physical, mental, emotional preparation in the years between diagnostic and surgery. This patient actually contacted us eager for surgery, and we told her not now. We told her she wasn't ready. That happens every now and then, and patients respond either with anger or saying, I really appreciate that. Give me some pointers. What do I do next? And that's great. That we love that. But if it is, we feel it's our ethical responsibility for these patients who invest a lot of money and their own and risks on a surgery, that they have the best optimal conditions possible for the best outcome possible. And if there are things that we know that the patient can improve in order to have a better outcome, it is our responsibility to make sure, as much as in their control and our, that those optimal conditions are in place before surgery, because it is a risky surgery and is an expensive surgery. And so we really want them to have the best outcome possible. And sometimes that means we say not now. Sometimes that means we say you need a better support system. It means we need to say you need to gain some weight. You need to improve your nutrition. It means you need to have better communication with your local healthcare team. It means you have toxic relationships in your life that are going to affect your ability to recover once you go home. All these things, it means you need some better tools in your emotional mental toolbox. And that was the case with this patient. She took it like a champ, went back home and worked really hard to not just gather tools, but to use tools so they were at her reach when she was really in the heat of surgery. So here's her video. Welcome, please meet this lovely patient from the UK, and she's going to explain to you specifically what this journey looked like for her. Can everyone hear this audio? Because sometimes audio is tricky. Everyone hearing this audio?
No.
No, are you serious? Okay, there's something I have to do.
You have to enable to play the audio through.
Yeah, where do I do that?
Not sure on the webinar setting.
Optimize for video clip. I know I've done this before, but it's been a while. I don't remember. Anybody out there remember what you have to do in order to hear audio in a video? All right, I've clicked a few things here. Let's see what happens.
In my quality of life, functionality, independence, and overall well-being in the year since my surgeries.
We're here.
Of course,
yeah, okay, let me start it over again.
That allows me to. Was essential in ensuring this positive outcome. But another important. Hello, I'm the patient from the case study, and as you will have already read, I've had a massive improvement in my quality of life, functionality, independence, and overall well-being in the year since my surgeries with Dr. Gilete. Of course, Dr. Gilete's skill and expertise was essential in ensuring this positive outcome, but another important contributing factor was the preparation that I undertook in the 2 years between diagnosis and surgery. So I'd like to talk briefly about what I did in the lead up to surgery and what other patients can take away from that. So the first type of preparation I did was investigative. So what this meant was seeing specialists and ruling in or out as many conditions and diagnoses as possible that could be contributing to the symptoms that I was experiencing. These are highly invasive major neurosurgeries with a long recovery time and some risks and potential complications. So if there are other conditions causing or contributing to symptoms that have less invasive treatment options like physiotherapy or medication, then the first line of action should always be to try those treatments. Now, the most important type of preparation I did prior to the surgeries was mental. So as you'll have seen from the slides, I have a history of primary psychiatric disorders. Prior to my surgeries, I had just completed a 2-year course of psychotherapy, so I was in a good place mentally. But it's really important for all patients, regardless of whether they have primary psychiatric conditions, whether they have reactive depression and anxiety as a result of their ME and the impact it's had on their life, to prepare themselves mentally for the surgeries. So three key things that I would say for mental preparation are having realistic expectations, so understanding that these surgeries are not a treatment for ME. We don't know what the relationship between ME and CCI is at this stage. We don't have enough data, and not enough research has been done. Second really important thing is understanding what the surgeries entail, what the complications and risks are, and what the implications are for your life, in terms of the reduction in range of motion in the head, or in my case, complete loss of range of motion. That's a huge anatomical change. You need to make a lot of adaptations to your life and the way that you do activities, and certain things you won't be able to do post-surgery. So it's really important that patients are aware of that. And a third really important thing is building up an arsenal of coping mechanisms and techniques to deal with the stress of the surgical process and of the rehabilitation process post-operative. And then just the last thing is logistical preparation. So that's not really relevant to you as medical professionals, other than to say that it's important that patients have appropriate care back home. So a primary care practitioner who is on board with them having the surgeries understands these conditions, at least to the extent that they can, and is supportive of prescribing any medications that are needed post-op and helping to follow Dr. Gilete's post-operative plan. Thank you very much.
So we can clearly see that this patient is incredibly well-spoken, has improved my cognitive function. She is brilliant. Sorry. And so that's the end of my presentation, Dr. Gilete's presentation. And appreciate your patience as he is not here. I've let him know that I'm still here, still connected, in case he's able to scrub out and run over to the office and connect. But meanwhile, if there's some questions that I can ask, I'm here. And if not, what I can do is provide an email address where I can forward questions to Dr. Gilete for any more technical issues. So let's go ahead and open up for questions. Isabel, are we ready for that, or do you have anything?
No, we're ready for questions. Rochelle's gonna take the lead on that.
Cool.
So I'm Rochelle. I hadn't had a chance to introduce myself, so I'm one of the volunteers with Renegade Research. And so I'll be kind of leading this a little bit on it. So one of our panelists, Dr. John Houghton, he's the first one we're going to go to for a question. And so, John, if you're ready to go.
I think my video is not on, and I think yeah, so I'll go ahead and just ask the question. So
can you restart the video, Rochelle?
I'll see. I just put the ask to start video. We'll see if that brings it up for him. Oh, there he is.
Okay, perfect.
Okay. Hi. First, great presentation. Thank you very much for pinch hitting so completely. It's not always an easy thing to do at the last minute, but and in some ways your patient stories and feet on the ground make it even more personalized. So thank you very much.
I appreciate that.
So some of the questions in the Q&A are asking about, given that there's a whole sequence of steps and seeing clinical impact before potentially doing surgery, and some questions about trying to, the idea of is traction dangerous? And I think you touched on that the general manual traction with a collar typically has not been dangerous. But just comments about that progression period of somebody looks like they have a clinical process going on that could include tethered cord or potentially ultimately a need for surgery. And then what people can do in the meantime in terms of symptoms? Are there things that are
okay? Sure. So for CCI and AAI, things you can do for symptoms. First thing you want to do is control as much as possible the comorbidities. So getting POTS under control, if that means getting them on some fluids, means getting them on some beta blockers, mast cell under control, because all those things can kind of really make the whole situation so much more unbearable. So first line of action is first really trying to treat the comorbidities. And then that also lets us to see, what symptoms might be coming from where, what is possibly brainstem compression, and might be, just a simple muscle activation disorder, which brainstem compression can cause autonomic dysfunction, which all those things we talked about come from as well. So it's, once again, like we talked at the very beginning, what comes first, the chicken or egg? Are these just simple ME/CFS issues, or are we looking at dysautonomia because of a brainstem compression? And the answer is we don't know until we do imaging sometimes. And we still don't know what's coming from where. So first thing to do is to control those comorbidities as much as we can in the non-invasive ways. Then if we're then suspecting instability, the first thing we want to do is stabilize with a collar. And then if that gives us some positive results, then trying patient guided traction. And that means the patient is the one doing the traction. And we never, ever want to hear of an over-the-door traction device. Never. There are even some inflatable devices that are not metal-flow devices that, in my opinion, could be dangerous because they could stretch some ligaments. And we don't want snap, crackle, and pop chiropractic treatment. If you have an AO chiropractor or a NUCA chiropractor, chiropractors used to be a bad word in our practice, but we've actually been speaking with some NUCA and some AO chiropractors that may possibly know something and might not be the devil, and are starting to try and see that there might be solutions beyond surgery for patients that are less invasive. But what we want to avoid is continuous, really aggressive stretching of those already really delicate ligaments with over traction. And so want to just do gentle traction in the collar. And if a patient is showing with stabilization and improvement with traction, and if they're able to do that for a few hours a day to get maybe some more hours of their day, then that is actually an appropriate treatment tool. Is, with a collar, I can actually finish my studies in the day. With a collar, I can actually take care of my kids, or I can come downstairs and have supper with my family. And so once again, it's one of these things that patients kind of have to decide for themselves. However, I do want to mention, since we're talking about collars, that overuse of collar can get us into the cycle of dependency. Some physicians are really hesitant to recommend a collar because of fear of muscle atrophy. So a cervical collar can be a great tool, but you can become dependent on it because the more you use it, the more you need it because of muscle atrophy. So if we're prescribing collars for our patients, we really need to make sure that with the collar, we're also prescribing isometric exercises. Crucial, those two go together. If you only are giving them the collar and they're loving it, they're like, oh my gosh, I have a life again. We really risk them being in it too much and then developing muscle atrophy, which every time they take off their collar, they're going to go, oh my gosh, I can't hold my head up. My symptoms are so much worse than they used to be. Oh, I'm having terrible symptoms. My case is progressing. I need surgery, when all it really is a case of muscle atrophy. So help me, please. If you're using a collar, isometric exercises, they don't even need to go to PT. Tell them to Google it. PTs are dangerous if they're not familiar with connective tissue disorders and ME/CFS. You guys know this. If they're not aware, if they're not ME aware, they can really, really make it worse. So be very careful, but isometric exercises are the easiest things in the world. Cervical exercises, I'm doing them right now. So really need to engage those muscles if we're on a collar. So once again, prescribe the collar, prescribe isometric cervical exercises.
That's a great point and observation. So important. And I just want to make one other comment before passing it off. That is, you were talking about the some of the brainstem clinical issues that get seen when you've got bony compression or instability. And it makes me think that within some of the medical side of ME/CFS and long COVID, the idea of inflammation in the brainstem and the sickness response, that there's really no reason why the damage or lack of blood flow has to be mechanical blockage or inflammatory blockage, and so that it sort of zeroes in as the brainstem is another piece of evidence of how it's so important across the board to be thinking about it. So
another tool we've been using more frequently recently in patients with especially viral onset or with even with Lyme disease is using biomarkers to kind of give us some more information about what's going on in the body of this patient. And in some cases, we might recommend IVIG or even some other treatments to reduce that immune response. So we can see really if what's going on is a chronic mechanical issue that could be fixed with surgery, or maybe they do have surgery, but are they going to even improve after surgery if they're still dealing with chronic inflammation and a chronic immune reaction? So those are other, I know that those are kind of, especially post-COVID, those could be kind of, what's the word I want? They can be a little controversial, IVIG and plasmapheresis, but they are treatments that we have considered for patients with chronic, especially with positive biomarker signs. So that's something else I'm sure you guys are all also looking at or aware of, but we're neurosurgeons, but we have to know a little bit about everything. And we do work with a lot of other professionals to fill in the holes of our own knowledge.
Right, for the next set of questions, Ellie, did you see any in the chat that you wanted to, the question Q&A that you thought would be good to bring up? Or should we try to bring in some panelists from speakers from or questioners from the Q&A itself?
Why don't we try to bring in some of the questioners?
Oh, all right. So I know that Jake H was actually asking quite a few questions. Jake, if you want to talk, I can. You can if you'd like to bring up a question.
Sure. I just had a few, I think, relatively basic questions. Let me just get them up again. So you mentioned sexual dysfunction in tethered cord patients, and I was wondering how much that relates to hypertonic pelvic floor muscles, and then the sort of the perhaps preventable factor of like being able to actually work on them because of these hypertonic muscles that might be as a result of tethered cord.
I'm going to flag that as a doctor question, but I will say that that's why evoked potentials are really important, because evoked potentials are going to evoke potentials. What they do is look at the messaging and the speed of communication from the brain into the spinal cord and nervous system. And so a lot of patients will present with what has been diagnosed as pudendal neuralgia, and really all it is tethered cord. And so that's why those evoked potentials are such really helpful tools in really narrowing down that we're actually looking specifically at a spinal cord issue and not something that could be more neuralgia based, muscle based, some of those other issues. But what you're asking specifically, I can't answer to, not being a doctor, but I can speak generically.
I'm happy to take a quick answer at it. So with the peripheral or central nervous issues versus peripheral nervous issues, if it's peripheral, it tends to be floppy, and if it's central, it tends to have more tone. And it's not a perfect statement.
Gotcha.
It can be a mixture of the two. And so the thing of evoked potentials or anything where you're checking from the brain on down is how long does it take? And so is there evidence of the nerve not conducting as well? Or sometimes it'll be done with a magnetic evoked potential. And all those things just help to look at the integrity of the wiring. And if you have a spinal cord injury and a complete transaction, you end up often having a bladder that's very contractile and very so it tends to be spastic. And so then the treatment for that would be to relax things versus if it's very, very low in the cord, you can have a floppy bladder that just holds urine and stuff. And the pelvic floor muscles would tend to work in a similar fashion.
Well, that also, we're getting back into the overlap with connective tissue disorders, because a lot of patients with connective tissue disorders are also going to present with prolapse. And so that's another reason why things like evoked potentials are so important versus urodynamics, because a patient with EDS is also going to have a poor response to urodynamic testing.
Well, thank you for that.
I'm
Great
sorry,
answer.
I couldn't.
Appreciate
I don't
No,
know
no,
that I would
that
classify that as a great answer.
that with John's help there, that answers my question fairly well.
Thanks. Thanks,
The
John.
only other question I had was I believe you went over this, but I just was confirming with lumbar prone MRIs, because generally speaking, most people won't have the same setup for the MRI or the same technology to sort of filter out the breathing data. Is a regular lumbar MRI more advisable, just to have some data?
Yeah, I mean, it's better than nothing, supine MRI, just to check to make sure there's not conus descent. But I will tell you, the majority of our patients with tethered cord do not have conus descent. And so, I mean, perhaps in a supine MRI, you might see something. You can look for fatty buildup around the phylum, but you'd have to have a really, really good MRI in order to see that in the axial-clefts. You can look for signs of arachnoiditis and root clumping in a supine MRI, but the prone, in our opinion, is so much more helpful in this population of patients. I will just throw out there, because we did work so strongly with the Bateman Clinic in Salt Lake City. There is a clinic in outside of Salt Lake City who follows some of our imaging protocol. They do not have a CBCT machine. We've been really pushing, trying to explain how cheap it is. As of yet, we haven't got them convinced. I'm just hoping we can drive enough patients to them that it makes it, like, financially viable for them. But they are doing excellent prone MRI exams, and they also do the 3 Tesla TOF no contrast vascular scan, and we get some really good prone MRI imaging from them. That technology is out there in a decent diagnostic center with the 3 Tesla machine. They have a new 3 Tesla machine. They have the software to reduce respiratory artifact. The problem is the technician has never used it before. They're not comfortable doing prone scans, especially on complicated patients like this. So the nice thing about having kind of the central place to send people is the technicians know what these patients look like. They're not freaking out. They know that their heads need to be in a neutral position. They know that they might need to take some breaks. They know that that they have some pretty severe symptoms and that they need to take it easy. If you're only sending patients, if a clinic is only doing one prone MRI a year, they're just not going to ever get better. And they don't know what it looks like, and they don't know how to do it well, and they're just going to say, no, it's too hard, it's not conventional, why not do a supine? Because everything I've ever learned about tethered cord says it has to be supine. So the benefit of trying to find a center that regularly does these scans, they're going to do them well. You're going to have a technician who knows how to do it. They're going to have the software available and the technique available, and they're going to be flexible and compassionate with these patients.
Okay.
So I'll just throw out the name of that clinic. They're called Envision. ENVISION. Envision Draper is the name of the clinic. They don't give us any money. We just happened to train them while we're in Salt Lake so that Bateman Horn Center had a place to send patients to. They do flexion extension. They do flexion extension in the supine position, which is better than nothing. And the imaging is quality, and it's somewhat weight bearing because they're in a kind of inclined position and the head drops. So it's better than plain old supine. And this Bateman Horn Center doesn't like sending patients for an upright MRI because it makes patients feel so ill and they feel so poorly after doing it that they don't ethically feel like they can send patients to Denver to do scans that the quality might not even be good enough to diagnose, which is why they're sending patients to do the supine flexion extension scan, which is understandable.
All right.
That was a long answer to a really short question. Sorry.
Thank you.
All right, so we're going to move on to the next questioner, Athena Hall. Are you ready to ask your question?
Yes, I am. First off, thank you for that wonderful presentation. If Dr. Gilete was the improved version, you both are doing incredible. So
oh, you're so
thank
gracious.
No, thank you. You really did a wonderful job. My question relates to if there's an opportunity that you see for a global collective effort, for example, including a task force of neurosurgeons, neurologists, internal medicine specialists, infectious disease, for example, similar to the committee that Dr. Huey has formed and has, for example, Dr. Ruhoy on board, including patient collaboratives that have really, as you indicated right at the beginning of your session, a very knowledgeable patient group that have done their research. Do you see an opportunity for that to grow? Because I see that, you know, we have an odd person in New York, Mount Sinai. We have an odd person, Dr.
Yeah.
Henderson, who you alluded to, who will be retiring soon. We have Dr.
He's the
Gilete, and I
godfather.
think, yeah, and I think we have Dr. Goal as well that hits the map, but we have a few people across the world. Do you see an opportunity for us to build on this work together, including the patient forum?
That's a
And
great
how
question.
would you see
That's a
that
great
rolling
question.
out?
So we work with the EDS Society as much as we can. They tend to be very UK and US centric. So we have had a hard time establishing ourselves as quote unquote authorities on EDS in the field of neurosurgery. We try within these societies. We would love to collaborate better with these other neurosurgical specialists as well. It is challenging because every doctor has their preferred surgical techniques. Every doctor has their preferred imaging for example, Dr. Bolognese only likes supine scans because upright imaging, the quality is so bad. And so he uses a supine MRI, 3T supine MRI, cervical supine MRI, and looks for hints that they're apparent in some patients with really advanced stages of instability, and then does invasive traction testing. Then Dr. Henderson likes upright MRIs and cervical rotational CTs, whereas we have our lovely CBCT protocol here. We, of course, are going to say everyone should use CBCT. It's the best. But things take time, and people like the way they do things and the way they've always done things. So unfortunately, where's medicine concerned, there's ego involved. A lot of times we're talking about collaboration, but we do have an active relationship with Dr. Henderson and Dr. Bolognese. We share patients, we share information, we see each other at conferences. I would love to see more collaboration. Our challenge, I'm just going to be really honest with you guys. Our challenge is we're a purely private clinic, purely private. We're not attached to a university. We receive zero public funding. So everything we do, we are self-funded. And by self-funded, it hurts my heart to say we are patient-funded. We do what we do because patients pay excessive amount of money for surgery and for diagnostics. No, we are nowhere compared to the cost of, I'm an American. I can talk trash about the U.S. healthcare system. It's like, no one's allowed to talk about your family, but you, like, no, I'm an American. Allow me to talk bad about the American healthcare system. We're much cheaper than the alternatives, but it hurts my heart when patients come to us and tell me that they, I don't like getting emotional. When they've had to mortgage their home to have surgery. It hurts my heart when they do fundraising. It's actually really beautiful when they do fundraising, but it's just not the way things should be done. I don't know what the solution is to that. It's unfortunately the only way we can work because of the way the healthcare system works in the world. In theory, EU patients should be able to get surgery covered in something called the cross-border initiative, but it practically never happens. In theory, if you don't have a specialist in your area, you should be able to find a specialist anywhere. That never happens either. So our challenge is that we're fully private. And what is that? Why am I answering this question by mentioning this? We are really challenged in research because in order to do research, in order to attend conferences, in order to do a lot of outreach, we have to stop working. And if we stop working, we don't eat. So that's a challenge of being a private clinic, is that we have to work. And I'm going to be very honest about this too. We are not Americans. We rest. I'm American, I don't rest. But that's not true either. I have a month-long holiday in August. We talked about patient mental health. We are very protective as well, that in order to do the really good job that we think that we do, we are very protective of our own physical, emotional, mental health and balancing our lives out as well. So I will tell you, this is going to be shocking for you guys. We operate maximum 2 patients a week. Because as I just presented to you, we know these patients inside and out. And we don't work with insurance. So there's not the pressure to operate in order to meet our quotas and in order to get that overhead. So we work differently, but it has its benefits, because we find a solution and we can implement it, because we don't have a hospital system that's telling us we have to do things this way, and oh, I'm sorry, you can't do it that way, because we don't have insurance telling us what we can and can't do. We find a solution, we can implement it. We can give our consultations often last an hour and a half. You can't do that when you work with insurance. And so our situation is very unique, but it does inhibit our ability to do a lot of networking and a lot of collaborations, because we spend so much time actually working. That was a very indirect answer. But can I just say, if you guys have any connections, I'm always, like I said, we just made a great contact with an AO, a chiropractor that just moved to Barcelona. So we're always looking for other professionals with open minds, with compassion, with curiosity, who want to help make things better for patients, and who want to find ways that perhaps for us, what in the perfect world, patients are coming to us much, much, much sooner for diagnosis, and not waiting so long for a diagnosis. So patients, I'm going to answer a question that hasn't been asked yet, but it's a common question. If I'm not planning on staff surgery, why should I be diagnosed with CCI and tethered cord? Especially with CCI, early diagnosis is huge. It's huge preventatively. And because it can give you some of those tools that we talked about to try and manage your lifestyle in a way that would perhaps prolong or avoid surgery. So knowing that if you have, oh gosh, I have CCI, maybe I shouldn't do jujitsu. Oh gosh, I have CCI, maybe I should wear a neck collar when I'm in a car. So all these things, I have CCI, maybe I shouldn't, maybe I should have my kid stand up before I pick them up. All these things are really important to diagnosis to prolong or avoid the possibilities of surgery. So we would love to come up with some more solutions to help patients get to us sooner, which a lot of times happens because we're talking to people like you. So you guys are opening your eyes to these clinical signs. And so we'd like patients coming to us earlier for diagnosis and exhausting more alternatives to surgery before they become surgical candidates.
And I'll add in there really quick that is some of the work that Renegade Research is trying to do, is network clinicians of all types worldwide. We're working really hard to make this happen, and we know that the time is so precious and so limited. So if we can do a lot of the work to make those connections and to facilitate the teaching and the networking and being able to expand that full of clinicians worldwide, that's what we're doing.
Thank you. You're all doing a wonderful job. And thank you, Amy, for your recommendations. I just have one final question regarding the publications that you alluded to. Could you give us the timing and the content that is expected to be released? Because, there may be some other global publications as well in tandem, but I'd like to hear about the ones that you are looking at issuing in the context of the CBCT you mentioned and some others, please.
Just give me one moment. I'm so sorry.
While Amy is off for a second, I also just wanted to make sure that you guys are aware that with the Renegade Research does have a dedicated Slack channel for clinicians in order to be able to network and discuss with each other. And there is a link to the sign up form if you'd like, that's in the discussion. So you can click on that if you'd like.
I'm so sorry. Can I get that question repeated?
Yes, you had mentioned some publications which will be released upcoming. I'd like to know, could you advise of the expected timing and the content which you expect in the various publications, including the CBCT you mentioned?
So we just hired a research coordinator, because as I mentioned, we're not connected to any kind of university or public funding. So we just hired a student who just finished her residency and is transferred from another country to Spain. And so she's going to be doing full focus on research. And so our right now we have 3 focuses: is publishing outcomes, results of surgery, then also publishing our CBCT paper that's all but ready to send out, and then publish. We've also been petitioning the various committees responsible for tethered cord diagnostic criteria to change the diagnostic criteria to include prone MRI imaging as an acceptable diagnostic tool for diagnosing tethered cord instead of just occult tether. So we're hoping, oh golly, some of these we've been working on for years, but this is the first time we actually have a designated team member who's and she's published previously. And so this is the first time we've had a team member who is not fully focused on clinical care and patient care, dedicated to research and publishing. So we're hoping, hopefully this year.
Okay, and I think we have about maybe one more question we can get to, and then I think we're already a little bit over time anyway. But so we'll go to one more question, and that's Antonius. Are you ready to ask your question?
Thank you so much for an excellent presentation. I would maybe ask just the last one. I can tell why CCI surgery is last resort, but why so for tethered cord? What is the danger of a tethered cord surgery?
So tethered cord surgery is definitely a much safer surgery. It is also cheaper surgery, and it has a lot less risks and complications. So we didn't even talk about, with a cranial cervical fixation, we didn't talk about it. You're basically handicapped for the rest of life because you can't move your head. With the C0 to C2 fusion, it's 50% of your head movement. With the tethered cord surgery, your biggest risk is retethering. Your biggest short-term risk is things like every surgery is infection, CSF leak, or fistula. Unfortunately, we don't see those very often, but they're real risks. And it's true. A lot of patients ask, if I have tethered cord, are there any other treatments? Because you can use a collar. Some patients do respond well with physical therapy as well for CCI. Some patients have even had some results, whether short-term or long-term, with things like prolotherapy. There's been no, I would just want to say now, there's been no published studies so far on the effectiveness of prolotherapy or cell treatments on CCI, and it can be quite dangerous procedure, because if we're talking about CCI and AAI, it's through the mouth. And so there's been no published studies on the effectiveness of those treatments on CCI. But some patients have reported some improvement, whether short-term or long-term. There is only, I do want to also say throughout this as well, that I'm aware of, there's only one clinic in the world who does through the mouth safe prolotherapy, and that's in Colorado. Just want to throw that out. But we can't recommend prolotherapy because we haven't seen enough scientific information about it. So what I was saying, sorry, is there are some treatments for patients to prolong surgery or avoid surgery for CCI. For tethered cord is tethered cord. It's tethered. Like, there's really no way to treat it. Some patients respond well to low dose, maybe steroid use, but that's a terrible idea long term. You can't do that. Some patients may respond well to cannabis, but it doesn't. None of these actually cure tethered cord. They may help with the inflammation or the arachnoiditis going around it, but really the only treatment for tethered cord is a tethered cord release. You'll hear out in the world perhaps about something called extradural tethered cords. Dr. Gilette's opinion is those are not viable. You can't detether for extradurally something that's tethered intradurally. It just doesn't make logical sense, nor has there ever been any study on extradural tethered releases being effective. Patients' experiences, I have heard maybe of a patient or two who have said that they've had positive experiences for extradural tethered cords. The problem with extradural tethered cord releases, as well as the practitioners who are doing them, a lot of times sell them as being a solution to everything. And we're a little wary about that as well. So just so you know that we do intradural tethered releases, and we do not believe in the science of extradural tethered cord releases. That being said, back to your question, what's the danger of a tethered cord surgery? It's surgery. So you want to be careful that, bang out again, what are the effects on my quality of life? What are the possible benefits from surgery? Weighing those out before you decide to go into surgery, and really looking again on making sure that there's correlation between symptoms and the actual neuroimaging diagnostic, and trying to get as much information. That's what we have. We actually have 4 diagnostic tools for tethered cord. We have the prone MRI. We have traction testing. That is a diagnostic tool. If the patient feels horrible in traction, then that's a really good sign that something's going on with that cord down there. Then we use the evoked potentials. And I'm missing one. Where are we? Oh, symptoms. Ha ha ha. Most important one. Symptoms. So, putting all those together, descartando, what does that mean? What does descartando mean, Isabel? I forgot in English.
Ruling out.
Ruling out. Ruling out the other symptoms that may be related to the other comorbidities, and then just deciding, okay, like, is it worthwhile to do a tethered cord surgery? But you are right. Tethered cord surgery is less invasive, less risky, and it is cheaper, and it has no long-term debilitating effects if there are no complications and if there's no retethering.
Thank you so much, Amy. Thank you for a wonderful job. We are so appreciative of you.
Guys, I'm so sweaty right now. You have no idea.
You did an amazing job, and we're very, very thankful. We have the list of questions that are remaining, and we'll forward them to Amy, time permitting. Whatever they can answer, we'll forward it on an email.
You're all welcome. You're all welcome. My personal email address is assist @drgilete.com, and our generic email that, here's the big secret, sometimes Dr. Gilete looks at, is info@drgilete.com. And we also have a website that has some information about our imaging protocol, and there's also contact us there on the website. If there are questions, you're welcome. Don't hesitate to send me questions by email. If I don't know the answers, I'll send them over to Dr. G.
Wonderful. Thank you so much, Amy. And thank you everyone for attending today. We'll have the video posted to our YouTube channel, Remission Biome, as soon as possible. And as always, thank you for everything today. Bye, everyone.
Have a good weekend, everyone. Thanks again, guys, for the opportunity.
Bye.